Good morning, ladies and gentlemen. I'd just like to start off by thanking Dean and the other organisers for the invitation to come and speak to you today and try and give a brief overview of some of the potential techniques and applications that exist for using hyperpolarized probes. We're all well aware of the ability of magnetic resonance imaging to non-invasively assess the human body without ionizing radiation and the potential advantages that offers to us. We get fantastic structural and functional information from inside the human body with very good soft tissue contrast. But the technique suffers from an inherently poor sensitivity. That poor sensitivity in terms of imaging is overwhelmed by the high concentration of protons in the body. But when you move over to the associated sister technique of magnetic resonance spectroscopy and you want to start looking at lower abundance nuclei and lower concentration molecules, things like proton spectroscopy, carbon-13 spectroscopy, the information available from these techniques is phenomenally high, but the amount of signal that we have there is very, very low. Now, not to start at too basic a level, but if we go back to the very, very basics of how MRI works, if we take something that we want to image, we put it into a magnetic field, and all of the atoms inside that sample will act like small bar magnets, and they'll line up with the magnetic field that we've put them in. But they'll line up in one of two orientations. They'll either align in the same direction as the magnetic field or directly opposite to the magnetic field. And what we do is we want to take the system away from that nice equilibrium and move it into a different state. So we input RF energy, which causes some of those spins to flip upside down. And then as they relax back to their normal state, they put out energy again, and we can detect that energy and turn it into an image. Now, the problem is that the number of spins that are orientated in those two different dimensions is pretty much exactly the same, and therefore the sensitivity or the signal levels that we can measure are very, very low. And that's the problem that we've got to try and battle. So we move over to the topic of today's discussion, which is hyperpolarization. The question, what do we gain? Well, the obvious answer is signal, because that's the thing that we're chasing with MRI. And what we can see is that the traditional approach to try and overcome this signal battle has been to increase the magnetic field strength. So if we take the assumption that the signal coming from a 1.5 Tesla MRI system is equivalent to a sort of a penny piece, apologies for the UK currency here, you can change that to your currency of choice. It's about the same as a cent or a euro cent or a dime, I think. The approach generally taken has been to move up in magnetic field strength. So if you go up to the sort of now more routine clinical field strength of 3 Tesla, you'll get about a doubling in field strength. A doubling in the amount of signal that you get from that signal. If we use these techniques of hyperpolarization, what we get is monstrous changes in the amount of signal. So we're talking the size of a skyscraper building, 10,000-fold changes in the signal that we're observing. So we're getting 5 orders of magnitude increases in signal. And the ability to start probing some of these interesting pathways and molecules that we haven't previously been able to see. So there's a kind of an envelope of different techniques that are all brought together under the umbrella term of hyperpolarization. So one is the approach that I've just mentioned, this kind of brute force approach where you increase the magnetic field strength, and you can take that to vast extremes. There are 20 Tesla MR systems out there. You can also drop the temperature, and there are techniques and approaches whereby a sample's placed into extremely high magnetic fields and at very, very low temperatures. But that sort of approach is relatively limited in its biological application. The optical pumping of noble gases, which I'll talk a bit more about in a second, has been very, very useful for inhalation-type experiments for imaging the lungs. There's a technique called parahydrogen-induced polarization, or PHIP, or others have termed it Pasadena, which is very, very useful for looking at other nuclei, things like carbon-13. Again, I'll talk a little bit more about that. But my disclaimer here is that my background is looking at a technique called dynamic nuclear polarization, specifically using dynamic nuclear polarization to image the heart. And so probably a relative focus of the talk will be on that, but I'll try and give a pretty reasoned coverage of all the techniques as well. So if we look at the hyperpolarized gases, what we use is laser light with circular polarization to deliver angular momentum to atoms. So we irradiate a sample which has got some metal vapor, alkaline metal vapor, and they absorb the circularly polarized light at a specific wavelength, and they acquire that angular momentum and become more polarized. If we then bring in and introduce noble gases, things like helium-3 or Xenon-129, those noble gas atoms collide with the polarized metal atoms, and that transfers this increased polarization onto the noble gases, so that we end up with a very artificially enhanced polarization state where lots more of these nuclear spins are pointing in one particular direction, so we have a high signal level. So obviously a gas with high signal is very good for inhalation type experiments, and so we can use that for structural lung imaging. Any obstructions or restrictions to the breathing pathways prevent the transfer of the hyperpolarized signal from the inhalation into the areas of the lung which are damaged, and so it's very, very good for looking at areas of obstruction, things like looking at people who smoke and areas of non-symptomatic damage to the tissues, or also looking at people with asthma and other chronic pulmonary diseases. But also we can bring to bear all of the normal techniques that MRI offers in a normal situation. So things like diffusion weighting, we can acquire diffusion coefficient maps which give us a better window on structural alterations. So particularly in patients with emphysema, the alveolar spaces are increased, and so the apparent diffusion coefficient is increased as well, because in the normal situation we're in a restricted diffusion situation. So if we look at a normal healthy individual, you get a very uniform ADC all across the lungs with a relatively low level, and in a patient with emphysema you end up with very high levels of ADC, but with a lot of inhomogeneity throughout the lungs. Now, there's a lot of comparisons being made between the use of helium-3 and Xenon-129. This is just a very brief table of some of the differences between the two. One of the obvious differences is that the production of helium-3 is coming from an artificial source in terms of the decay of tritium, and makes it a very expensive gas to acquire, and with a relatively limited supply. That the initial developments of helium-3 seem to be slowing somewhat and transferring across to Xenon-129, which in its natural state is relatively cheap, but if you want to enrich it, comes up to the same sorts of costs as helium-3. It's got a slightly lower gyromagnetic ratio than helium, and therefore the signal level is a little bit reduced. But one of the advantages with xenon is that it's soluble in liquids, so there are potentials for using it as an injectable agent as well as an inhalation agent. But also, as you inhale it, it transfers across the pulmonary wall and into the blood. And so there are techniques which are looking into that. So one of the advantages with the dissolved phase helium signal is that it has a shift in frequency away from the gas phase. So you can isolate the two. So you can look at the gas signal and look at the liquid-based signal at different chemical shifts. And that then allows you to generate these sorts of images of, this is of a rat brain, looking at the dissolved xenon within the rat brain. And there's a lot of work going on at the moment looking at whether that could be a useful technique in terms of functional imaging, looking at areas of brain activation, because the chemical shift and the relaxation properties of that dissolved xenon change on the oxygenation state of the blood in a similar way to protons. And so you can start to get some information from that perspective. The other technique that I'll briefly discuss is parahydrogen-induced polarization, or Pasadena. This involves utilizing one of the isolated states of hydrogen. So normally hydrogen can exist in one of four states. The predominant one is orthohydrogen, which is a triplet state with lots of different spin orientations, whereas parahydrogen's got a very highly conserved spin orientation with one spin up, one spin down in an anti-parallel fashion. And this parahydrogen becomes the predominant form at very low temperatures. So if you take hydrogen down to low temperatures, you can get to an isolation of parahydrogen. What you can then do is take that very high polarization within the parahydrogen molecule and involve it in a chemical reaction through a hydrogenation step, and then introduce that polarization into the hydrogenated molecule, and then through some various techniques of RF pulsing, transfer that polarization across to a molecule of interest. Particularly 13C has been very well used, and you get very, very high levels of enhancement using this technique, and relatively rapidly as well. So going from a thermal polarization, this is of ethanol, which is 3 or 4 orders of magnitude below integers up to something of the order of 20% polarization, so where 1 in 5 atoms is polarized in the right direction. So you can get vast orders of magnitude increase in signal to noise in the spectra that you're acquiring. So this is just a brief schematic of how that works. So you take your parahydrogen, introduce it into a hydrogenation reaction, which then obviously separates the hydrogen molecule, brings it across the double bond, breaking the double bond, and then if you transfer that polarization across to a 13C molecule through RF transfer, you can start to get high levels of polarization on the 13C molecule. So this is the sort of a basic schematic of a parahydrogen polarizer. You need a cavity which has got a relatively low magnetic field and an RF coil for doing those transfer reactions at the end. You need the molecule that you're interested in polarizing ready to take place within the chemical reaction, and you need a supply of parahydrogen. So what you do is you introduce your sample into a heating block to bring it up to an appropriate temperature, which takes of the order of about 45 seconds. You then bring in the parahydrogen to the sample space, and then using a nitrogen chase the sample into the molecule. The hydrogenation reaction takes place very, very rapidly, and then through a pulse transfer program, you can generate the hyperpolarization onto the carbon-13 molecule, and you've got a hyperpolarized sample which can be generated very, very rapidly. So one of the major advantages of this technique is it's very, very rapid. You can get very frequent turnover of the hyperpolarization. And just a couple of example slides of the use. This is from the Pasadena group, looking at using hydroxyethyl propionate as a contrast agent for vascular imaging. So you can use it as a tracking agent through a catheter. You can use it as a vascular agent in the right ventricle or in the lungs. But one of the problems that parahydrogen has suffered is this need for this hydrogenation reaction. And so there needs to be an element of chemical specificity to be able to generate a molecule with high polarization. That is starting to be overcome with the introduction of some new techniques. A technique called SABRE has been introduced, which I think is on the program for next year's talk. So we'll be talked a lot more about next year, and we'll probably have some more interesting ones. But there's certainly new applications coming forward for parahydrogen in Pasadena, and it's definitely moving forward as a technique, but it's a little bit behind the other two techniques at the moment, but is certainly catching up. So the final technique that I'm going to talk about in a little bit more depth is dynamic nuclear polarization. Now, this was a hyperpolarization technique that was first proposed in the 1950s. It was first demonstrated in the 1970s, but it's got a requirement for the sample to be in the solid state, and that requirement has definitely limited its biological application until very, very recently. When in 2003, the group working in Malmo demonstrated that they could take a solid state DNP polarized sample and dissolve it very, very rapidly and retain some of that solid state polarization in the liquid state. So this is the seminal paper from Ardenkiar Larsen, where they were demonstrating more than 10,000-fold increases in liquid state NMR signal. Here's an example of urea thermally polarized, and then the hyperpolarized sample exactly the same, and demonstrating this massive increase in signal to noise. So the basic process is you do the solid state DNP process, which I'll talk a little bit more in the next slide. You then go through a rapid dissolution stage and then injection. So you get the possibility to generate a very rapidly high signal MR contrast agent that can be injected in vivo as a contrast agent. So how does it work? Well, similar to the way that NMR works in itself, you take the sample and you put it into a magnetic field, and the spins line up. Some of them line up with the field, some of them line up against the field, and generally you've got about the same number in both situations. If you add in a source of electrons, they do the same. They line up, some of them line up, some of them line down, but again, pretty much the same number in both orientations. But if you now freeze the sample, take it into the solid state, and take it to very, very low temperatures, so we're talking sort of the order of 1 Kelvin, you can get very, very uniform polarization of the electrons. Because of their higher gyromagnetic ratio, they struggle to achieve the higher energy state, and therefore they drop into this lower energy state and become very, very polarized. If we then introduce a microwave irradiation, we can transfer that electron polarization into the nuclear spins and generate a system where you've got almost uniform polarization of the nuclear spins in that situation. And that's where we were in the 1970s, and that worked very, very well. The step that Ardenkier Larsen introduced was a very, very rapid melting stage, which allowed us to bring that into the liquid state and use it as an injectable contrast agent. So how do we actually do it? So we take the sample that we want to polarize. It's generally carbon-13, but particularly Dean's group have been looking at other molecules and other nuclei to polarize. We then need to introduce a source of electrons, a radical, which takes very different forms. Very often the trittle radical is used in that situation. And then you can also introduce a very, very small amount of gadolinium contrast agent, which tends to affect the electron relaxation properties and enhance the level of polarization you get. You mix those together into a sample cup, and then you introduce them into a polarizer system. So this is just an example of the two systems that we've got in Oxford. One's a prototype system, which was based on the design that came out of the Malmo group, and then a commercially available hypersense system, which automates the dissolution process. So this is the dissolution stage that was proposed by Ardenkier Larsen. So you've got your sample immersed in liquid helium, so it's down at very low temperatures at 1 Kelvin. It's in the bottom of a high field, sort of 3.5 Tesla MR system, and it's been polarizing for about 45 minutes. So that's definitely one of the disadvantages of this technique over parahydrogen, is that the duration of time taken to enhance the polarization is much longer. You then take a buffer solution that you're going to use to melt that hyperpolarized sample. So in the situation where this is an acid, you very often use sodium hydroxide here to neutralize the pH. And you'll heat that up and pressurize it. So you tend to heat it up to about 200 degrees C, pressurize it to about 10 bar. So it's very, very hot and pressurized up there. You then raise the sample up to atmospheric pressure, raise the sample out of the liquid helium so that the temperature differential is not too high. Drop the dissolution stick, docking it with the sample holder, open the valve, inject the solution, it melts the sample and brings it back out under the pressure into an injectable form, which you can then take forward into your experiment. So this is hopefully, we were having some problems, just a movie demonstrating that. So the sample's been polarizing. We've got our solvent in the top area of the dissolution stick here. The sample space is being pressurized. It's being brought back up to atmospheric pressure. That's the longest bit. We raise the sample up, lock it in place, dock the dissolution stick, drop it down, open the valve, and it's melted very, very rapidly. Now, the only problem there is that things start to decay back to thermal equilibrium very, very rapidly, and so you need to start moving at a reasonable pace. But you can inject the contrast agent in, and then you can see the appearance of the molecule that you've injected, but also its downstream transformation into the other molecules that it subsequently becomes. There's also, I said, this hypersense machine, which is basically an automated version of exactly the same system. So the dissolution process there is automated, and there's no need for, it sort of attempts to remove some of the variability of the prototype systems. Although I tend to think that a lot of the prototype systems are a little bit like a Formula One pit crew. They can get a lot better, but that's just our opinion. So this is just an example of pyruvate or pyruvic acid at thermal equilibrium. So this is a spectrum which took somewhere just over 3 hours to acquire, 2,500 averages. And this is exactly the same sample after hyperpolarization. You've got a signal-to-noise ratio there of 480 in a single sub-second acquisition. So that's a 22,000-fold enhancement achieved after dissolution compared to thermal equilibrium. So you can see the sorts of orders of magnitude signal enhancement that you can gain through this technique. So what do we need to make a good DMP probe? Well, DMP theoretically should work on most small molecules, but there are some disclaimers to that we would really like our ideal probe to be. It should freeze as a glass and not crystallize, and that's to enhance or to allow the polarization process to take place. We need to achieve a high polarization in a reasonable time. So some molecules will polarize, but they take 4 or 5 hours to polarize, which sort of limits their utilization, or they only achieve a relatively limited polarization state. There they need to have a relatively long relaxation time. So I said once you've done the dissolution process, things start to decay back to thermal equilibrium, and they do that via relaxation processes in exactly the same way as all MR experiments will recover back, and that's via this the T1 mechanisms. And so if you've got a relatively long relaxation time, you've got a relatively long period of time to use that enhanced signal. And in the same sense as that, they should have rapid biological uptake, and they should reasonably show multi-step metabolism. There are exceptions to those 2 points, but the ideal probe really should follow those points. And the vast majority of work that's been done in this field has been done using hyperpolarized pyruvate labeled at the first carbon position with carbon-13. And it ticks all of those boxes of what an ideal probe should be. So it freezes as a glass, as a pyruvic acid is available as a liquid, and it freezes directly as a glass. Other molecules can be frozen as a glass, but they tend to need glassing agents to try and help them to get to that situation. It polarizes very well, so you can get a polarization of somewhere between 20 and 40% in less than an hour. Higher field strength polarizer systems are coming online, which are taking that up to the 50 to 60% sort of mark. It's got a relatively long T1 in that first carbon position, so the T1's somewhere of the order of 60 seconds. It's very, very rapidly taken up into cells through the myocardial monocarboxylate transporters. Thank you very much. And it plays a very, very central role in the pathways of carbohydrate metabolism. So as the pyruvate goes into the cell, it's converted into lactate via lactate dehydrogenase, into alanine via alanine aminotransferase, and then it's taken on up into the mitochondria, where it's cleaved into acetyl-CoA, which goes on into the Krebs cycle, and into CO2. And that CO2 is in very, very rapid equilibrium with bicarbonate, and that equilibrium is determined by the enzyme carbonic anhydrase, and so it's a kind of a pH-dependent equilibrium, but the bicarbonates there are in a vastly higher concentration. So we tend to observe resonances coming from lactate, alanine, and bicarbonate. There are a range of different ways that you can acquire data from these hyperpolarized traces. The most obvious and simple one is to just use a simple spectroscopic method. The tracer is injected into a sample or into an anesthetized animal via a tail vein or any other vein that you want to use, previously positioned in the MR system. The spectra then generally get localized with the use of a surface coil or slice selection to narrow down the field of view. This is just an example of the localization we use on our cardiac samples. And then you acquire spectra for 1 to 2 minutes as the signal decays following injection with high temporal resolution, low flip angle RF pulses. I'll talk a little bit more about that in a second. But what you see is the injection of the pyruvate coming in. It's been clipped here because it's much, much higher. And then its decay back to thermal equilibrium over its T1 time. But you also see its conversion into its other molecules, so its conversion into lactate, alanine, and bicarbonate. If you come way downfield here, you can also see its conversion into CO2. And you also can see the non-metabolic transformation of it into pyruvate hydrate, just due to the pyruvate being in solution. So that's a sort of a typical time course of the spectra that you'll see. So you can use the pyruvate bolus as a sort of a normalization step to give you an idea of the polarization that you achieved in the first place, but also its decay rate. And then you can see its metabolic conversion into the downstream molecules. But you see this very, very enhanced signal window here from sort of 18 to 50 seconds after injection, which gives you a potential window for metabolic imaging and imaging of these hyperpolarized tracers. So just a couple of points to think about before we move into imaging. Following the hyperpolarization, T1 is a decay process. It's not a recovery process as it is in normal MR experiments. And that means that anything we do to the sample will tend to destroy the signal. So any RF we apply will destroy the signal that we've enhanced rather than introduce it. And there's no chance to recover that lost magnetization without re-going through the polarization process. So we need to be very sensitive to signal decay and also to the involvement that we use. So we need to try and use low RF pulses or sort of single shot techniques so that we minimize our RF exposure. In terms of imaging challenges, well, we generally want to acquire spectroscopic images, and therefore shim and spectral resolution become very, very important. We need to be able to localize different resonances within an MR spectrum. But we also need to be able to image fast and without too many RF pulses. Dynamic images are obviously an advantage because then you can observe those sort of time courses and start to look at metabolic exchange rates. And from our point of view, cardiac imaging or any torso-based imaging, we need to cope with motion in the form of ECG and respiration gating, probably. Specific imaging challenges for looking at 13C nuclei as opposed to protons. Well, the chemical shift of carbon-13 is generally very broad, which is a good thing, so it spreads things out, so that helps with our spectroscopic localization. But the gamma is low, it's about a factor of 4 down on protons, and that means that the signal and the gradient demands become much, much higher. And just generally because of availability, we tend to be using surface cores, and so homogeneity is a slight issue. So some potential strategies that have been applied, just a simple low flip angle chemical shift imaging approach was used initially. It's very simple, it's widely available on most MR systems, it's not particularly demanding on the hardware, but it does use a lot of RF pulses and tends to take quite a long acquisition window with low spatial resolutions, and so it tends to be relatively limited in terms of multiple time point imaging. Single shot techniques like echoplanar spectroscopic imaging or spiral techniques tend to be taking over. They allow us to do very, very rapid single shot imaging with very few RF pulses and low RF demands. But there's a need for good B-naught sensitivity, and it is very demanding on the gradients of the MR system. And also single frequency approaches are being promoted a little bit more now. And so they're generally taking the form of these spectral spatial pulses, which tend to have been proposed primarily by Chuck Cunningham and his colleagues over in Toronto, which allow for simultaneous slice selection and RS selectivity. So we can select a slice within our sample, but also selectively excite just one specific particular resonance. So the pulses tend to have pass bands and stop bands where there's no excitation, where there's frequency excitation, but there's also spatial localization in the other domain as well. So you can pick out one particular resonance and just excite that, and then just shift the frequency of the pulse and choose different resonances to acquire. You then just attach that to a sort of spiral readout acquisition, and then you can start to get very, very rapid images. So it also allows you to pick out the different resonances and at different flip angles. So you can use very low flip angles on the pyruvate, which is coming in, but higher flip angles on the bicarbonate and the lactate, which are being regenerated constantly. So this is just an example of some cardiac images utilizing that. So you see the bolus arrival of the pyruvate in the ventricles of the heart, but then also its metabolic conversion to bicarbonate and lactate in the walls of the heart. Now, in terms of application for this technology, probably the primary application has been looking at oncological applications, primarily tumor response and tumor localization. And what you see is that you can start to use the inherently glycolytic nature of tumors to detect the response of the tumor to treatment. So this is just one example of many, many publications that are out there in the literature from Kevin Brindle's group in Cambridge, looking at pyruvate and lactate images of a xenograft tumor. You see a relatively poor perfusion of pyruvate into the tumor, but very, very high levels of lactate coming through its glycolytic conversion and exchange of the 13C label into a pool of existing lactate there. And then after treatment, a vast reduction in the level of the lactate generation, showing the death of the tumor before you're starting to see changes in tumor volume. Other applications, particularly from my focus, cardiac metabolic imaging, allowing you to look at metabolism within the ventricles of the tissue and see how that varies upon disease and how that varies with myocardial infarction and things like that. This is the original paper on that application from the Malmo group of Klaus Goldman and colleagues. Some other applications that the Malmo group initially proposed, which haven't really moved forward in perhaps the way that they could have done. So angiography is one obvious application. Because you generally have no background signal from any other carbon-13 molecule, you get very, very high contrast to noise, which makes it very, very useful for angiography. So you only see the injected tracer and where it goes. From a similar line there, catheter tracking is another potential application. And direct quantitative perfusion imaging. So rather than using a contrast agent like gadolinium, where you're looking at concentration effects of the gadolinium on the protons within the blood pool, you're here looking directly at the perfusion of the tracer into the tissue, and so you can get hopefully a quantitative approach to perfusion. Pyruvate's not the only molecule. It's certainly the one that's been used used predominantly, but many other compounds have been proposed. This is just a 5-minute flick through the literature that I did last night when putting the slides together, but there are many, many other molecules that are being proposed, and they're coming out faster than I can put a slide together on them. Bicarbonate, which I'm going to talk a little bit more about in a second. 13C fumarate is being proposed as a marker of cellular necrosis. 13C glutamine is being proposed as an oncological agent looking at tumor metabolism. Coming back to that bicarbonate, I said originally when talking about the conversion of CO2 to bicarbonate that was a pH-sensitive reaction, and the group from Cambridge hyperpolarized bicarbonate and injected that into tumours and looked at the ratio of the bicarbonate and CO2 levels to do a calculation of extracellular pH using the Henderson-Hasselbalch equation. And so the ratio of the two signals therefore gives you a measure of extracellular pH, and you can see the alterations in pH within the tumour where you get a reduction in pH due to the acidic environment. You can also use 1,13C pyruvate to try and measure intracellular pH. So in this situation, as you inject the pyruvate, the CO2 generated is therefore intracellular, and therefore its conversion into bicarbonate becomes an intracellular pH measure. And what you see is that after a brief period of normalization, the ratio of the CO2 and the bicarbonate gives you a pH which calibrates with intracellular pH measured from phosphorus spectroscopy. But there is a need just to be a little bit cautious about these pH measurements, because it does rely on a very, very high level of activity of carbonic anhydrase. So if you inhibit that carbonic anhydrase activity, you end up with a pH measurement which is below the true pH measurement, just due to the fact that the system can't get into equilibrium, and therefore the ratio is not giving you a true measure of pH. But it is possible to do that in vivo. So these are some spectra coming from the in vivo rat heart, where you can start to get pH measurements in vivo in that situation. One of the other beauties of this technique, as with all MR techniques, is that you've got chemical specificity to which molecule within which atom within a molecule you're looking at. So if you transfer the 13C label over to the second carbon position within pyruvate, you can still monitor those transformations into lactate and alanine. But now, rather than the 13C molecule being cleaved off as CO2, it's carried through into acetyl-CoA and on into the Krebs cycle. And so you can start to acquire resonances coming from TCA cycle intermediates like glutamate, citrate, and acetyl-carnitine, and start probing those sorts of pathways. And that's being particularly useful for looking at the ischemic heart, where alterations in glutamate seem to be markers of myocardial disease.
Call 911.
What about rising blood pressure from binge drinking? Could set off a hypertensive crisis, cause heart failure.
2 drinks is hardly a binge.
Certainly not if you're an Aussie. But when an American schoolgirl has 2 drinks before 10 a.m., it's a pretty sure bet that the plan is to have a lot more. Probably was the first time she had that plan.
We'll get a C13 pyruvate MRI to check for cardiac lactic acid levels.
It's not our best shot. I'm pretty sure it's our only shot.
Now, I'm not proposing that we use House as our definitive guide for clinical medicine, but more so that there is the potential for clinical application of these technologies, and that has been taking place in terms of phase 1 clinical trials with the group at UCSF, particularly Sarah Nelson, Dan Vigneron, and John Kahanowitz as the PIs there. But about 2 years ago, they were given their phase 1 approval from the FDA, and they've moved forward from that point to do their first phase 1 clinical trial. In this situation, what they've done is they've embedded the polarizer into a clean room, allowing sterile preparation of the compound and its eventual injection. A pharmacist watches through the window to approve the release of the compound before it's injected. So it's sort of similar to a PET tracer from that perspective, but with a much shorter time window for release. And this is just a couple of slides stolen from their presentation at the ISMRM a couple of years ago, where you can see in a prostate tumor patient In the benign area of the prostate, you only see the pyruvate that you inject. You don't see its conversion into lactate because of the lack of glycolytic metabolism. Whereas over on this side, where there's a biopsy-proven tumor, you see a very elevated level of lactate being generated from that pyruvate due to the glycolytic nature of the tumor. You can do that in an imaging response as well. So here, where you can see a T2 abnormality in the prostate, you can also see elevated levels of lactate within the tumor. And even over here on this side, which has subsequently been biopsy proven to be a tumorous area, you can see elevated lactate despite no abnormality on the MR imaging as well. There are approaches to move forward with this technology to generate a clinically suitable device which can do that compounding without the need for a clean room. It's got a lot of features that will help it: multi-sample polarization, large doses for clinical utilization, and above all, the ability to do that all in a sterile processing manner. But in conclusion, what we can see is that hyperpolarized probes can offer us increased sensitivity, particularly for very low SNR MRI and MRS applications. There are a range of different techniques, all with their own advantages and disadvantages, and probably the route forward for these is to combine those to generate the appropriate technique to answer the question that you're trying to get at. But their use in preclinical research is now relatively well established, and their utility in clinical research is certainly under investigation and moving forward at a rapid pace. Thank you to everyone involved with my group, those people that gave me slides, and apologies to those who I stole slides from because I didn't have a chance to get hold of them before I went away on holiday, and also to all the funding bodies, and to thank you for your attention.